So, palliative care. Y'all might have heard me talking about the idea of there are some providers who actually believe once we get the diagnosis, we should be moving into cause no pain, cause no harm, provide support, provide comfort, and do the right thing for the person in their support system. Most individuals, however, don't look at palliative care that broadly. For them, it's something that happens near the end of a dementia. And what's the difference between palliative and hospice? And we did talk about that, but in general, palliative is providing comfort care, whereas hospice is providing end-of-life care. So if we were to look at those variables, everything from, I'm saying, when it comes to dementia, once you've decided you're not going to beat it, what do you do? To, we wait till we're right at that point where I need you to be comfortable. I don't want you to be uncomfortable. What do you all have experience when it comes to, for your experience, what about you in palliative care? What would you say?
So for me, so my mom went on hospice, but was on hospice for almost 2 years, actually, before she died. And in actuality, really, she's probably a palliative program would have been more appropriate.
How many times did she almost get discharged from hospice because she got better?
Many. She just kept, but the thing that kept her on hospice was that she kept losing weight. Right. And that was the thing.
Yeah. And she needed assistance and all, and she couldn't communicate her needs. And she met the other criteria, but this thing that she would really brighten up and be able to do things for a bit. And then with the Lewy body, it was on off, which quite honestly, hospice is not set up to identify Lewy body as a particular dementia, which makes it sort of tricky. But so
so for palliative, thinking about it more broadly, palliative care to me is just being able to live your best life comfortably for really as long as you can, but it's much more of a focus on quality of life versus quantity. And, it's not as specific as hospice where you have to meet this criteria and you have to be evaluated periodically and all this. And when you go on hospice, you can't have any therapies. You can't have any PT, OT, speech, anything like that.
No recovery. You can't have recovery.
Right. Yet on a palliative care program, you absolutely can. Yeah. So, I think my message would be for folks who, have a dementia diagnosis or any diagnosis, really, it's not just limited to dementia, but is to really understand, what a palliative care program might look like for their person. And put that out on the table to see if that might be a good choice at whatever time is right. And probably involving the person living with dementia
in that process, in that
conversation, which we did not do. So if I could rewind the clock, I think
that would be something to involve your mom in those kind of choices and thoughts.
Absolutely.
Okay. Yeah. Right.
Yeah, but it does change with time. With the initial diagnosis with Martha, it took a while to understand. Okay, we're not going to recover.
Darn.
Yeah. And so.
Did you have that same feeling with your parents?
My parents were in their 80s and 90s, and it's like, oh, this is end of life. We knew it's going to end.
Okay, so it wasn't just because of their dementia; it was the increasing age as well, and you were looking at the whole picture. But when it came to a young, vital woman, it's much
57.
harder to get your brain in that space.
Right. Yeah.
To consider this as a life-ending condition, and yet not give up on life.
We didn't give up on life, and early on, we traveled and we lived a pretty full life. But there came a time when that just wasn't going to happen, and it sort of happened when we moved to the more supportive community.
Yeah.
And there, I had to answer a question that I wasn't really ready for. I was ready for it because Martha and I talked about it, and the question was, "Do you want us to call 911?" It's like, so if you think she's having a heart attack, do you want to rush her to the hospital? And they said, yeah, that's what we're asking you. And it's like, no, if that's your ticket out, that's your ticket out. And we discussed that.
Yeah, because there's more than dementia that can end your life.
Yes.
I mean, there's lots of options
That's
that
right.
life ends, and it's not all about that it's going to be your dementia.
Right. And at that point, if she'd had colon cancer, I mean, she wouldn't have been able to understand the treatment. And you have to ask yourself, recover to what?
Yeah.
Okay. So early on,
And
we still had
treatment looks like what?
right. That's
Yeah.
right.
Yeah.
So early on, it's like, yeah, we've still got life. And I'm not saying we don't have life to live now, but it's just different. And so if it's something that's causing pain and discomfort, we would treat that.
Yeah.
Urinary tract infection? Absolutely.
Yeah.
Take some antibiotics, we're
Yeah.
good to go. Because that would cause discomfort.
Yeah.
But if it was a major diagnosis,
Okay, so now I'm gonna push a little bit.
Okay.
Because I have this experience. So we treat one UTI and she gets another one within a very short window. And then we treat that one and she gets another one. Now we have to up the antibiotic and we have to go to something more powerful.
Right.
And this time when she takes it, now we've actually destroyed some bacteria in her gut, and now she ends up with C. difficile positive. Right. And now we're having to deal with C. diff, and she's in isolation. Everybody's going to have to be gloved and gowned, and she can't see faces. And we maybe even get through that, but she's lost a lot of weight, and now she's... So the next UTI...
Right. Yeah, so the UTIs have a way of evolving, and they'll respond to this antibiotic.
And now
but,
we're at
but then
the fourth generation.
Right.
Yeah.
And that's actually what my dad died of. Urinary tract infection.
Yeah.
And we had to make the decision.
He became septic, and that's...
Yeah,
and we're not going to treat it again.
We're just not going to...
We're not going to do this again. We're going to make him comfortable.
We're going to make him comfortable. And that's where the hospice comes in, and they help you with that decision.
Okay.
And there are ways you can treat the pain that keep him in comfort. And that's what we did.
And I wanted to do that because people tend to think of, oh, it's just a UTI. But the reality is it isn't just a UTI.
Right.
I mean, it can be the signal that the system is really to a point where it can't keep going.
Right.
And how many times do we do it before we say, okay, that's enough.
Right.
We're not going to put her through that again.
Yeah. Yeah. So try the first time, and if they fully recover, good. If they don't, it's like, okay, maybe this is it.
Maybe this is it this time.
Right. And again, you got to think, what's life like if
what
they
would the
do
treatment
recover?
be? Yeah, what is this, and what's life going to be like if we do
And
make
virtually
it?
everybody says, well, I wouldn't want to be like that. Well,
but then
what makes you think Dad wants to be like that?
Yeah.
Well,
Yeah.
It's good to just talk through those things.
It
ahead of
is,
time.
and have the conversation many times, because we think we know, and then we move forward, and then we think, well, now wait, let me think this time.
Right.
Okay, Regina, your thoughts on this one?
And I'm glad that you mentioned about having dementia and other things, right? And because we often assume that if they have dementia, that's what's going to take them out. So my grandmother had breast cancer and dementia at the end of life. And so I remember getting the phone call about, Nanny's breast cancer has started to spread. And, can you come up here and go to this appointment, because now they're talking about radiation. And she's 92, right? And so, and I was grateful that they respected my knowledge and wisdom to come up to help them make that decision, right? Because at the end of life, we were dealing with some palliative things, but then we went into hospice, right? And so once we went into hospice, it was like, we're not doing anything curative at this point. We are strictly providing comfort. And what the radiation oncologist's thought process was that radiation was not to treat, but it was to provide some comfort. Because even radiation can be palliative if it's going to decrease
with
the
her
pain.
dementia. So that always becomes the question sometimes. Can she hold still for it? Would she be okay with it? Can you have a family member in providing support for it? I mean, because again, dementia adds this other layer and this other thing that we want to add in. And it was important that somebody who gets both cancer, radiation, but then add dementia on, so that we're making, and you can try it and then go, okay, that radiation treatment was a disaster. Or it worked great. It worked much better than I thought it would. But still have that option of, okay, we're here for comfort.
Right.
That was not comfortable.
Exactly.
Or it was.
Right. And in our experience, it was.
Yeah.
And so, quality was much more important than quantity, because we knew that we didn't have much more time with her, because she was already progressing in the dementia anyway, when they realized that now the cancer has already spread as well.
Yeah.
Yeah. So, it's still hard to make the decision.
It is hard.
Right? It's never an
it's
easy
never
decision.
easy to have some role but not taking a role isn't helpful.
Exactly.
Yeah.
Exactly.
So thank you for your sharing. I think all too often people think hospice and palliative are the same, or they think palliative means you can't do anything except provide comfort. And it's like, well, comfort comes in many shapes and forms and variations. So thank you for the work that you've done in discovering what it means to support someone through the end of living.